Okay. So before we start the optics of astigmatism, we have mentioned something about the back vertex distance. So let's have more information about what's called the back vertex distance, or BVD. So the back vertex distance is the distance between the back of the glasses or the back of the correcting lens and the apex of the cornea or the anterior corneal surface. So again, this can be measured by either a simple ruler or by the scale which is present on the side frame of the trial lens frame. So it's about 13 millimeters between the back of the cornea or back of the correcting lens and the anterior corneal surface. It can be measured by different methods like the millimeter scales on the trial frame and the exophthalmometer and the Zeiss parallax vertexometer. So here is the trial lens frame. You can see that when we put there will be always a back cell in the trial lens frame from which you can measure the back vertex distance either through a simple ruler or if the trial lens frame is provided with a side scaled frame like this, then you can measure it with it. Or the exophthalmometer exophthalmometer is a device that is used for measuring of the exophthalmos or the protrusion of the eyeball, but it can be used as well for measuring of the back vertex distance. As you can see here, there will be a scale with a mirror, and you can see that the apex of the cornea. If you put a trial lens in front of the eye, and you can measure the distance between the anterior surface of the cornea and the trial lens. Like here. There is a device called the vertexometer or distometer. Just know it by it. It is just a name. You don't know anything more about it. It is just a device that is used for measurement of the back vertex distance. And I don't think that this thing or this measurement needs such complex device. So what makes us more concerned about the back vertex distance is the significance of the back vertex distance, because the back vertex distance can change the effective power of the lens, as we mentioned in the previous lecture. So whether it is a plus lens or a minus lens, moving the lens forward or backward or changing the back vertex distance by increasing or decreasing can change the power of magnification of the lens. So increasing or decreasing the vertex distance will change the optical properties of the system by moving the focal point anterior or posterior, leading to a change in the power of the lens relative to the eye. So, as we mentioned in the previous lecture, the aim of correction of any ametropia is to bring the punctum remotum at infinity, and this can be done by that has an f2 which is coinciding with the punctum remotum of the eye. So if we have a punctum remotum in front of the eye, as in myopia, we need it to be at the infinity by using a minus lens with the f2 of this minus lens coinciding with this punctum remotum in front of the eye. If we have hypermetropia that has a punctum remotum behind the eye, we need to use a plus lens. This plus lens has a focal or f2, or this f2 should be coinciding with this punctum remotum behind the eye in order to bring this punctum remotum at the infinity. So this is what we have just mentioned. So the f2 here is the equal to the punctum remotum, or the f2 will be coinciding with the punctum remotum in order to bring the light rays to the retina at the f2, so that if f2 or the light rays emerging from the f2 will emerge from the eye parallel. So we bring here the punctum remotum at the infinity. In case of hypermetropia, the punctum remotum is a virtual point behind the eye, so we need a lens that has a focal length. This focal length should be, or the f2 should be coinciding with the punctum remotum of the hypermetropic eye in order to bring the punctum remotum at the infinity. So if the correcting lens is moved, here is the issue. If we move the correcting lens, the f2 and the punctum remotum are no longer coinciding. So the principle or the basic principle in correction of ametropia, that the f2 and the punctum remotum are coinciding, and so that they are conjugate points, as we mentioned. But if we move this lens forward or backward, then the f2 and the punctum remotum are no longer coinciding. That's why the retinal image size will change. So what will be the effect on the retinal image size? Let's repeat again the Knapp's rule. The Knapp's rule mentioned that if an axially ametropic eye is corrected by a lens present at the FA or F1, which is the anterior focal plane of the lens or of the eye, the magnification of the image size will be the same as the emmetropic size. So RSM equals 1. What is the relative spectacle magnification? It is the spectacle magnification, or the size of the image with the glasses or with the correction divided over the emmetropic image size. So if an ametropic eye that has axial ametropia, axial myopia, or axial hypermetropia corrected by a spectacle present at the FA or the anterior focal plane, then the image size will be the same. The retinal image size will be the same like emmetropia, so the relative spectacle magnification will be equal 1. So the retinal image size will be the same in the two eyes of axial ametropia, regardless the amount of error, as long as the lens is placed in the anterior focal point. But actually, this is not the case, as we don't place the glasses in the anterior focal plane, but we place it in the spectacle plane, which is about 13 millimeters from the anterior surface of the eye. So changes in the back vertex distance will lead to changes in the retinal image size. So what are these changes?
So according to the Knapp's rule, the retinal image size will be the same as long as the lens is present at the anterior focal point of the eye. So if the convex lens is present at f1, it will be the same retinal image size and it will be the same effective power, and we will talk about the effective power in just a few minutes. And also, if the minus lens is present at f1, then the retinal image size will be the same and the effective power will be the same. This is according to the Knapp's rule. But actually, if the image or the lens has a change in size in relation to the eye, it becomes moving more forward or more backward, this will result in changing in the back vertex distance and consequently changing in the image size and the effective power of the lens. So how does this occur? This will be different according to if it is a plus lens or minus lens. For a plus lens or minus lens, as we move the lens forward or backward, the image will move forward and backward consecutively. So this will not be different. But here the image size and the effective power of the lens will be different, because now when the correcting lens is moved either forward or backward from the eye, the divergence power at its principal plane of the eye is changing. They are no longer the same. And that's why the focus of the lens and the far point of the eye are no longer coinciding, resulting in changing in the image size and the effective power. So let's see this in more illustration. This is a case of hypermetropia. As you can see, uncorrected hypermetropia, the parallel light rays are falling on a point behind the retina because this optical system is too weak to converge the light rays on the retina. So the purpose of the correcting lens is to bring the image more forward on the retina. As you can see here, when we are putting a plus lens, the far point or the f2 has moving more forward toward the retina. And if we are moving the convex lens more away from the eye, consequently, again, its far point will move more forward. So as you can see here, as we move the plus lens away from the eye or more forward, and we are increasing the back vertex distance, the focal point of the lens will moving more forward to approximate the retina. This will result in that the effectivity of the lens is said to be increasing. So if even we are using a weaker plus lens and moving it forward, this will result in more image magnification and more correction of the hypermetropia and more effective power. The reverse will occur with the myopia. So in case of myopia, as you know, it is the parallel rays will fall on the eye and come to a focus in front of the retina. And the purpose of correcting the myopia when we are putting a minus lens is to just bring the image more backward. We want the light rays to diverge so that the focus will be moving more backward to fall on the retina. So what do you expect when we are moving the minus lens more forward? As you expect, again the image will move more forward, so it will be moving more further away from the retina. It will so that the minus lens, as we moving away from the eye, the size of the image will decrease and its effectivity will decrease because we are moving away from the retina. So let's get back to the table. So as we are moving the plus lens away from the f1, the size of the image will increase, and as we move the minus lens away from the f1 outside the eye, the image size will decrease and the effective power also will decrease. So I hope that this is clear now.
So the clinical importance that the spectacle plane is 13 millimeter, which is inside f1, which is 15 millimeter. So stronger plus lens and weaker minus lens is needed. So in order to maintain the same power, we need to, that's why we said that if we are putting glasses in the spectacle plane, if we need to increase the power, the power of the lens is more than the actual error in case of plus lens and less than the actual error in case of minus lens. If we put a contact lens, the application, if we put a contact lens inside the f1, which is inside the 15 millimeter, we need a stronger contact lens and a weaker minus contact lens. Again, as we move toward the eye, we need a weaker lens correction or weaker minus correction. And as we move away from the eye, we need to increase to the stronger plus lens is placed in the f1. If we move inside the eye or move inside the f1, so if we need to substitute the glasses with a contact lens, then as we move inside the f1, we need to a stronger plus lens. As you can see here, if we move inside, the image size decrease, so that in order to have the same image size, we need to increase the prescription. We need to increase the plus lens. So for example, if we have a patient who have plus 10, we need to a plus 12 in order to substitute it with a contact lens. And the reverse occur with the minus lens. So if a patient has minus 10 diopters and we need to substitute this minus 10 diopter with a minus contact lens, then weaker prescription is needed to maintain the same image size. So just put minus 8 or minus 7 and it will be the same of the retinal image size as the minus 10 of the glasses. So that's why we said that if a patient has a progressive myopia, so he has increasing the refractive error, and we need to do this minus lens is no longer working, and this patient needing to increase the magnifying effect of this minus lens, they tend to push it toward their nose. So they become inside the f1, more inside the f1, so it increases the retinal image size. While the hypermetropia, if the hypermetropic is increasing in age, and especially if he is presbyope, and he is now putting the glasses at the spectacle plane, and in order to see clearly, they, or to gain more magnifying effect, if they are getting older, they tend to push the glasses away outside the f1, so at the tip of their nose, in order to see more clearly and in order to see the near target with a more magnifying effect. Usually, these effects are not well documented in patients with small refractive error, meaning that if a patient has -1 or -3 or -4 or +1, +3, +4, this by the back vertex distance effect on the prescription will not be that significant. However, if a patient who has a large refractive error, like patient who have high myopia, or patient who have aphakia, so they have high hypermetropia, in such a condition, when you are doing glasses for them, you should mention at which back vertex distance you did the glasses, so that when the optician is performing or manufacturing the glasses, he will know what is the magnifying effect of the glasses that you made for this patient, so that he can take this into consideration while making his spectacle, as the spectacle has a fixed plane, which is the spectacle plane at 13 millimeters. So whether you just put the spectacle at 13 millimeters, or you putting your trial lens frame at 13 millimeters, or you should mention at which back vertex distance did you make the glasses. And these errors are usually significant when doing glasses for refractive error more than 5 or 6 diopters. Okay, so just to conclude the back vertex distance, we have two terms. One is called the anterior vertex focal length and the posterior vertex focal length. So the anterior vertex focal length is the distance between the anterior surface of the lens and the f1 of the convex lens and the f2 of the concave lens. Again, the anterior vertex distance, or the anterior vertex focal length, is the distance of the anterior surface of the lens and f1 of the convex and f2 of the concave. While the posterior vertex focal length is the distance between the posterior surface of the lens and the f1 of the concave and the f2 of the the f1 of the convex and f2 of the concave lens. So here, if we have a convex lens like this, here is the back vertex distance, the distance between the anterior corneal surface and the lens itself. We have the anterior vertex focal length, which is the distance between the f1 and the convex lens, and posterior vertex focal length, which is the distance between the f2 and the posterior surface of the lens. While in concave lens, we have the again the anterior vertex focal length and the anterior vertex focal length and the posterior vertex focal length. So in case of the concave lens, the f2 is lying in front of the eye, while the f1 is behind the eye. So the anterior vertex focal length, the f2 will be in front, between the distance between the f2 and the anterior surface of the minus lens, while the f1 is the distance between the posterior vertex focal length will be the distance between the f1 and the posterior surface of the concave lens. So let's now talk about astigmatism. So what are the optics of astigmatism, and what is the astigmatism? So A mean no or absent, stigma meaning a point. So these patients cannot focus into a single point. This is what simply astigmatism means, that this patient has different refracting surfaces over their corneas or over their optical system, that that these patients cannot make a single focus over the retina. This astigmatism can be divided or further subdivided into regular astigmatism and irregular astigmatism. So what is meant by regular and what is meant by irregular, and how to measure and how to correct that, this is what we will mention in this lecture. Let's start first with the irregular astigmatism. What is meant by irregular astigmatism? So irregular astigmatism, meaning that it is a refractive condition of the eye in which the incident parallel rays cannot be focused into a single point. So this is just the difference of astigmatism. So the eye cannot be focused into a single point. But why it is irregular? Because all meridians are different, so that it cannot be corrected with glasses. That in such a condition, they have bizarre configuration of meridians of the refracting surface. That's why no single glass can be efficient for correction of this irregularity. So, for example, if we have this is an eye and this is the cornea, and this cornea has a scar causing irregular astigmatism, so there will be different powers of refracting surface over this cornea. So areas of corneas are strong, areas are weak, areas are steep, areas are flat, so that the cornea will refract the light rays into different points, not a single point. So some points will be behind the eye, some points will be in front of the eye, some points will be at the retina, and there will be no effective lens that will cause all these irregular points to be focused into a single point in the retina. So what will cause this irregular astigmatism? It can be due to pathology inside the retina or pathology of the lens. So any irregularity of the cornea or the lens can cause irregular astigmatism. Like corneal opacity, for example, a trauma that, like here, as you can see here, that there was a rupture globe with evidence of sutures. Healing of this rupture will cause irregular astigmatism, and as due to this corneal scar causing irregular astigmatism. Or sometimes the healing of corneal ulcers can cause the same scars. Or if the cornea take the protruding shape, or what's called the keratoconus, so there will be bulging of the posterior or inferior part of the cornea, leading to formation of the cone. The refraction of this cone will be different from the refraction of the periphery, causing more myopia and more astigmatism. Or there will be conical protrusion of the lens, or what's called lenticonus. So the lenticonus, there will be protrusion of the lens. It can be either posterior lenticonus or anterior lenticonus, which will have the same effect on the light rays, causing difference in refraction and leading to irregular astigmatism. In such conditions, the glasses are usually not sufficient for controlling the condition, and it will not produce a single point from all refracted light rays. This can be differentiated from the regular astigmatism. So although the astigmatism, again, the regular astigmatism, it's a refractive condition of the eye in which the incident parallel rays cannot be focused into a single point, but the difference between it and the irregular astigmatism, that there is a meridian of maximum power and a meridian of minimal power with gradual transition in between, so that the image is formed at the conoid of Sturm. That can be corrected by cylindrical lens if it is a simple astigmatism, or a toric lens if it is compound astigmatism, as we will see now. So you can assume that the cornea or the lens or any refracting surface of the eye having different power of different meridian. So this is the vertical meridian, and this is the horizontal meridian. So the power or the curvature of this vertical meridian is different from the curvature of this horizontal meridian. So, for example, if we say that the vertical meridian is corrected by -2 lens, and the horizontal meridian is corrected by +1 lens. This is when we can say that this is a regular astigmatism if there is a meridian of greatest power and the meridian of least power, And now there will be gradual transition in between. So if the cornea, if we calculate the power of the cornea at this meridian, it will be -1. And here the cornea has no power, or it will be like an emmetropic. So it will be 0. Then it will be +1. Then it will be 0 again. So -1. Then from -2, then from -2 it will be -1 and -1. And this meridian will be 0 and 0, then +1 and the +1, then 0 and 0, and this meridian will be -1 and -1. So there will be meridian of greatest power and the meridian of least power, and there will be gradual transition of power in between. This what will make the correction of this regular astigmatism possible, because if we have different or irregular transition between the meridian of greatest power and the lowest power, then no glasses will be able to correct the bizarre configuration of this meridian. So as we mentioned before, the image in case of compound astigmatism, let's say that it's a compound astigmatism, so each surface, it has a meridian of greatest power and the meridian of least power. So each one of them act as a spherical lens, so it has form a point, or the spherical surface, the vertical meridian act as a spherical lens, so it has cause a point fixation or a point focus, and after light rays come to a focus into the point, then it will diverge, as you can see here, while the horizontal meridian is less powerful or less curved, so that it can make a point or a focus which is located far behind the anterior focus of the vertical meridian, and then after making the focus, they will diverge. The image that is formed by the convergent vertical meridian and the horizontal meridian will form a line. This line is horizontal, and this is called the sagittal focal plane, because this line is mainly formed by the horizontal meridian. So it is horizontal sagittal focal line, or horizontal focal line, and it comes with the coincident with the focus of the vertical meridian. On the other hand, the vertical meridian, after making this focus, will diverge, and it will form a second focal plane that is vertical, that come coincident with the focus of the horizontal meridian. So this is the second focal plane, and this is the first focal plane, and the distance between them is called conoid of Sturm, and the central point of this conoid of Sturm is called the circle of least confusion, which will equal to the mid-spherical value of the vertical and the horizontal meridian, as we said before. So again, here is the first focal line, and here is the second focal line. As you can see, the image was oval and then becomes circular. When the rays become at the much more or the most close proximity to each other, then the image become vertical again, vertical again, vertical again, until it makes a line. So the center or the mid-dioptric value between the anterior focal plane and the first focal plane and the second focal plane is called the circle of least confusion, which is equal to the spherical equivalent of this lens. So what are the causes of the astigmatism? It can be due to abnormality in the curvature of the refracting media, or a refracting error, or a curvature error, or obliquity of the eye elements. So the eye elements are just more oblique over each other. So for the curvature, we have can be due to lenticular, or what's called lenticonus. So the lens become more conical in shape, or more common to be corneal. So cornea can be normal astigmatism or physiological astigmatism. Sometimes there are, or not all of us are born with the refracting, with the meridia of the cornea are of the same power. So many of us are born with one meridian is more powerful than the perpendicular meridian, and in such a condition, It is termed physiological regular astigmatism. And this condition can be corrected simply with glasses, and usually it is with the rule astigmatism. And by saying with the rule astigmatism, we mean that the vertical meridian is more curved than the horizontal meridian. So this is the rule. Or the corneal abnormal curvature can be pathological. So it can be occur in case of trauma or in case of keratoconus, as we mentioned. The second reason of astigmatism is the obliquity of eye elements, and this can be also pathological or physiological. So physiological, sometimes someone born with an oblique cornea over the lens, over the retina, or it can be pathological, like for example trauma, that this trauma caused the subluxation of the lens, so that the lens is now not on the same axis of the cornea, so it will lead to irregular astigmatism. Or obliquity of the retina. For example, the retina is not like has the same curvature like the lens. For example, it has a pouch or has a curvature or bulge of the posterior pole of the retina, like in case of posterior staphyloma, or if the retina has abnormal curvature in case of high myopia. So here we can see that this is subluxation of the lens. So if the light rays passing through the center of the cornea, it will pass through the periphery of the lens. So this will lead to astigmatism because of the different refracting surfaces passing through this ray. Or if there is posterior staphyloma, so there will be bulge of the posterior pole of the eye. This will lead to this part will receive the light rays in a different manner than the normal eye. Types of astigmatism can be further differentiated according to the meridia, or according to the rule, or according to the symmetry. Let's start with what are the types of astigmatism according to the meridian. This is very simple. If we have the meridia of the greatest and the lowest power in the perpendicular, in the horizontal and the vertical direction, so this will be a vertical astigmatism or a horizontal astigmatism. And in both conditions, it should be the angle between both of them should be 90 degrees. So the angle or the angle between the meridia should be always 90 degrees to each other if the astigmatism is regular. So this is whether the vertical and horizontal, or if it is oblique, it should be 90 degrees. So the meridian of the vertical or of maximum power and the meridian of the lowest power should be perpendicular to each other. If these meridians are in the 90 and 180 degrees, then this is called vertical or horizontal. If they are not in the 90 and 180 degrees, then this is called an oblique astigmatism. So sometimes some have misconcept that a regular astigmatism or regular astigmatism should always have the greatest power and the lowest power at the 90 and 180, and this is not always the case. Sometimes it can be 180 and 90, and for many in many occasions it can be in the oblique direction. So it can be, for example, at 135, or at the axis of astigmatism is 135 and the perpendicular one will be at 45, or it can be at 10 and 170, and vice versa, or sorry, at 10 and 111, or 100, sorry, 100. According to the rule, what is the rule? The rule is that the vertical meridian is more powerful and more curved than the horizontal meridian. And this can be attributed by the weight of the eyelid. The upper eyelid exerts a weight over the cornea, causing more bulging and more curving of the anterior or the superior or the vertical meridian. So the vertical meridian become more curved than the horizontal meridian. and still the angle between them, or they are both perpendicular to each other. If this rule is reversed, meaning that if the horizontal meridian is more curved than the vertical meridian, then this is called an against the rule astigmatism. So, for example, this patient has no astigmatism because the refracting surfaces of, or the refracting media of the cornea are all the same. So the vertical like the horizontal, like the oblique, so all the same. While in this, his father has astigmatism, and the astigmatism is with the rule because the cornea is more curved in the vertical meridian than the horizontal meridian. While his grandfather has astigmatism as well, but this astigmatism of against the rule because the horizontal meridian is more vertical meridian. Dr. Magd asked about which is more common. About what? What is the what do you mean by more common? The rule, okay, is so usually the younger the age, it is more with the rule. So the more young the patient is, more with the rule astigmatism due to senile changes that occur in the cornea and the surrounding limbus and peripheral degenerations that may occur, like arcus senilis and the peripheral marginal degenerations. This with the age, then this is this with the rule astigmatism change to the against the rule. So with the rule is more common in young, and against the rule is more common in the old age. Yes, by saying more curved, meaning it is more convex. So it is more powerful. So this is an example of a patient with regular astigmatism with having the vertical meridian, which is more convex and more curved, and this is the horizontal meridian, which is less convex or less curved. You can see clearly that the horizontal meridian is more curved, so that it can, as you can see here, it is more curved, so it can make a focus which is in front of the retina, while the vertical meridian is less curved, as you can see here, so that the vertical meridian is more hypermetropic, so it makes a focus behind the retina. That's why it is called the astigmatism, because there is no single focus of all meridians, but the image is formed in the form of a conoid of Sturm, and this conoid of Sturm has a circle of least confusion, and the circle of least confusion is the mid diopteric value of the eye, or of the refracting power, but it is not a single point. How can we change the circle of least confusion to a single point? This can be done by fitting this patient with a toric correction. So toric correction, meaning that it is a spherocylindrical lens that has power in the refractive power of the vertical meridian, and different from the horizontal meridian. According to the symmetry, the astigmatism can be symmetrical, meaning that the meridia of two eyes are equally deviated from the midline. Like here, you can see that this patient has the axis of astigmatism has oblique astigmatism with the axis of at 120 degrees, and the axis of of the other eye is on the 60 degrees. So it is like a mirror image. Both of them are equally separated from the midline. This can be called symmetrical astigmatism. The asymmetrical astigmatism, meaning that the meridia of both eyes are not equally deviated from the medial line. For example, this patient has astigmatism that's present at the axis at 120 degrees and the axis here at 0 degrees. According to the refraction, so we have a simple myopic astigmatism, or that the patient, if the patient has myopia, then this patient will have -2 of all refracting surfaces of the cornea or of the eye. So all meridia will have the -2. But in case of a simple myopia, there will be only one meridian, which is here the vertical meridian, that is corrected by the -2, while the perpendicular meridian will be 0. So there will be have the meridian of the least power will be 0, and the meridian of highest power will be the -2. This is called the simple myopic astigmatism. On the other hand, the simple hypermetropic astigmatism, meaning that the patient has the one meridian which is immetropic and the perpendicular meridian which will be hypermetropic, that's corrected by +2. So this is simple. And in such condition, if we have simple myopia or simple hypermetropia, this can be corrected by a minus cylindrical lens that correct only the axis, the correct only one axis, like here the -2 at 90 degrees, and the simple hypermetropia will be corrected by plus cylindrical lens that correct only the hypermetropic axis, which will be the +2 at the 90 degrees. Then we have the compound myopic astigmatism, meaning that the patient has myopia in both meridians, or the both perpendicular meridians of highest power and lowest power, and they are both perpendicular to each other. So we have both are myopia, or both are myopic. So it's called compound myopic astigmatism. The same as well in case of hypermetropia, meaning that the meridian of greatest power and the meridian of least power are both hypermetropic. So this can be called compound hypermetropic astigmatism. If we have combination, so we have a meridian of highest power, which is myopic, and the meridian of the lowest power, which is hypermetropic, then this is called mixed astigmatism. So to have a better visualization of how does this looks like, if we have a patient who have a simple myopic astigmatism, then the meridian of greatest power and lowest power, both of them, the meridian of the greatest power will form a focus in front of the retina, but the meridian of the lowest power, which will be the immetropic one, will form a focus in the retina. The simple hyperopic astigmatism will have a meridian of greatest power, which will be the immetropic one, forming a focus on the retina, and the meridian of the lowest power, which will form a focus behind the retina. So both of them will be corrected by a cylindrical lens. The mixed astigmatism will have the meridian of highest power will form a focus in front of the retina, and the meridian of the lowest power will form a focus behind the retina, which will be the hypermetropic one, and such condition will be corrected by a toric lens or a sphere cylindrical lens. Compound myopic astigmatism has both the meridian of greatest and lowest power. Both of them will form a focus in front of the retina. So again, it can be corrected by a toric lens. And the compound hyperopic astigmatism, the meridian of the greatest power and the lowest power will form a focus behind the retina, so it will be also corrected by a toric lens. So what will these patients complain from? Sometimes in small degrees of astigmatism can be tolerated by the patients, so they become asymptomatic, or usually they complain from athenopia or ocular pain, headache, and the blurring of vision, usually more while with hypermetropic less than with mixed. And this can be very logic. So if the patient has the hypermetropia itself can cause athenopia because the patient is in a state of constant strain over his ciliary muscle. So suppose that this patient has, besides the hypermetropia, they have astigmatism. So not only they have a blurred image, but a blurred and distorted image due to astigmatism. So they will complain more from athenopia. And the athenopia is less than with the mixed type of astigmatism. And this is because in case of mixed astigmatism, they will have a focus in front of the retina and a focus behind of the retina. So the circle of least confusion will be on the retina. So these patients are more or less having better quality of vision than other types of astigmatism because of the centration of the circle of least confusion over the retina. So they will do better than other patients or other types of astigmatism. These patients will have decreased visual acuity. Usually they describe it as running letters, especially while they are reading letters or reading a book. And sometimes they will be present with head tilt to compensate for this astigmatism, and can sometimes present with half lid closure or slit-like to form a pinhole effect in order to increase the depth of focus and to try to overcome the refractive error. There are various methods for testing for the astigmatism, either subjective or objective. So this will be covered clearly in the refraction lecture. So just to summarize, the patient can be measured by the visual acuity using the visual acuity chart, or a device called the cross cylinder, or the astigmatic fan, or astigmatic dial, or stenopic slit. This will be mentioned in the or covered in the refraction lecture. Other methods for measuring the astigmatism will be objective, like retinoscopy, or autorefractometer, or the Placido disc, or the photokeratoscopy, or the pentacam, or the topographers, and also by seeing the oval disc in the ophthalmoscopy or in the fundus examination can also give us a clue that this patient have astigmatism. Treatment is based on the symptoms. So if there is no symptoms, then there is no treatment. If symptomatic, then this patient should receive full correction. But if the patient is not tolerant, or if the patient is old and this patient didn't wear glasses before, it is not wise to start with the full correction as the patient will not tolerate it. So usually the younger age group will tolerate the full correction, but the older age group will not tolerate full correction. So start with under correction if the patient is never worn or never worn glasses before, especially if they are old. There are different methods for correction of astigmatism. Usually they can be termed collectively in spectacles or contact lenses or surgery. So the spectacles can be used either in the simple form or the cylinder for simple astigmatism, or toric for compound and mixed astigmatism, in order to reduce the interval of Sturm and bring the two focal lines so that those rays will come to a focus on the retina. So as you remember these slides, in case of astigmatism, the circle of least confusion is in front of the retina or behind the retina or in the retina, and so that this is the interval of Sturm formed by the refraction by the toric surface, leading to anterior focal plane and posterior focal plane, so the image will be very blurred. If we put the circle of least, if we put the glasses or put a minus lens in front of the eye, this minus if we put the spherical equivalent in front of the eye, which will be the spherical mid value of the toric surface or the toric lens, then this will bring the circle of least confusion over the retina. So it will be the circle of least confusion will be now on the retina, so it will be less blurry, but it is still blurred. But if we want to make it sharp, like emmetropia, then we should put a toric correction in front of the eye, so that this toric correction will make the lens focus into a single point rather than a line or a circle. Other methods to correct the astigmatism, like the contact lenses, So it can be either a soft contact lens or hard contact lens, which is used mainly for the irregular astigmatism, or toric lenses that will correct the both sphere and the cylinder, or the refractive surgery like LASIK.